This is JAPI, and welcome to JAPI Podcasts.
In partnership with Torrent Pharma, by the makers of Nebicard and Telsar Biso, where science meets care.
I am Dr. Munish Prabhakar. I welcome you all to the JAPI podcast of the June 2025 issue of JAPI Volume 73, Issue 6. This issue of journal has some really interesting articles, including 6 original articles, 3 review articles, 1 point of view, 5 unique case reports, 2 pictorial CMEs, and 2 letters of correspondence. Let us discuss these all in details. The first original article is titled "A Study of Clinical Biochemical and Cardiac Profile in Snake Bite at a Tertiary Care Center in Northern India," authored by Tarun Pal et al. Snakebite represents a critical occupational hazard for individuals working in agriculture and outdoor labor, leading to significant global morbidity and mortality. Despite their impact, accurate global data are scarce due to patients often seeking traditional remedies over formal healthcare. This study aims to analyze the clinical, biochemical, and cardiac profiles of snakebite patients at a tertiary care center in northern India. Methods: this was a prospective observational study and was conducted at a tertiary care center. It included patients aged more than 13 years who presented with snake bites. Baseline investigations were done, and treatment outcomes, complications, and survival rates were monitored. Statistical analysis was performed using Statistical Package for Social Science version 24.0. Results: of 120 snakebite patients, 20% were under 18 years, 58.3% were aged 18 to 45 years, and 21.7% were over 45 years of age. Male to female ratio was 6:5. Most patients were farmer, 35%, and from rural area, 94%. Snake bites predominantly occurred during the monsoon season, affecting the lower limbs, 70%. The most frequent complications were acute renal failure and respiratory failure. Mean troponin T levels were higher in diseased patients compared to survivors, although this difference was not statistically significant. P is equal to 0.077. N-terminal pro-BNP natriuretic peptide pro-BNP levels were significantly higher in the disease group as compared to survivors. P equal to 0.010. ECG abnormalities included sinus tachycardia 25%, T-wave inversion 5%. The mean hospitalization duration was 3.42 plus minus 2.17 days for survivors and 4 plus minus 2.5 days for diseased patients without significant correlation to outcome. Conclusions: the study found an association between delayed hospital arrival and increased complications. Elevated potassium and serum SGOT levels were also observed in diseased patients, alongside higher respiratory rates and lower blood pressure and Glasgow Coma Scale scores. Pro-BNP levels were found to be significantly higher in diseased patients. Now let's go to the second article, which is a study of correlation of iron profile of elderly patients with heart failure in a tertiary care center, authored by Rudra Vaidya et al. This prospective observational study investigated the relationship between iron deficiency and heart failure in elderly patients. Conducted over 1 year in a tertiary care center, it involved 138 patients aged more than 60 years diagnosed with heart failure. The study aimed to determine clinical characteristic and correlate heart failure severity with serum iron, ferritin, and transferrin saturation levels. The average patient age ranged predominantly between 61 to 65 years, with 70.29% being male. Clinically, breathlessness, 98.55%, was the most common symptom, and basal lung crepitations were the most frequent sign. About 35.51% had reduced ejection fraction, less than 30%, and nearly half were classified as NYHA class 3. Results showed that a significant proportion of heart failure patients had iron deficiency, defined using low serum iron, ferritin, and TSAT values. Patients with lower iron parameters exhibited more severe heart failure symptoms and poorer NYHA classification. Anemia was also common, highlighting a multifactorial interplay between cardiac dysfunction and nutritional deficiencies. The study emphasized that nutritional iron deficiency, which is relatively easy and cost-effective to treat, can have a substantial impact on heart failure outcome. If left unaddressed, it proposed that routine screening of iron profile in elderly heart failure patients can lead to early intervention and improve overall disease management. Ultimately, this study advocates integrating iron status check into standard heart failure care protocols, especially in resource-limited settings like India, where dietary deficiencies are quite prevalent. This could reduce hospitalization rates, improve quality of life, and potentially decrease mortality in this vulnerable population. The next original article is on Mind the Gap, exploring discrepancies in perception and practice among diabetes mellitus patients and their caregivers, authored by Vivek Hari et al. This cross-sectional observational study from Kasturba Medical College, Mangaluru, focused on the gap between knowledge and actual practice in diabetes self-management among 750 participants, both patients and caregivers. The objective was to understand perceptions regarding diabetes complication, treatments, and lifestyle modifications. Although nearly all participants acknowledged the importance of lifestyle changes, patients 97.9%, caregiver 99.2%, practical implementation, especially of exercise, was poor, 56.8% adherence. Misconceptions were prevalent. 93.9% of patients believed long-term medication use harms organs, which can hinder compliance. Most were aware that diabetes can cause organ damage, but understanding of specific complications was low. Only 45% complied with the regular checkups, and a significant number found medical counseling inadequate. Limited comprehension of doctors' advice, 34.7% of patients and 32.3% of caregivers emphasized a communication gap. These findings highlight the importance of enhancing diabetes education to be interactive and continuous rather than one-off events. The study concludes that educational efforts must evolve beyond simply informing and should actively foster behavioral changes. It advocates for better integration of caregivers in the educational process and the development of more innovative communication strategies to bridge the perception-practice divide. The fourth original article is titled Correlation of Neutrophil and Platelet to Lymphocyte Ratios with Disease Activity in Rheumatoid Arthritis, authored by Bhupen Burman et al. The objective of the study was to correlate NLR and PLR with disease activity in rheumatoid arthritis, potentially offering simpler, objective alternatives to ESR, CRP, and DAS28. It was a prospective, analytical, hospital-based study including 74 rheumatoid arthritis patients and 74 healthy controls. Patients were classified using 2010 ACR Euler RA criteria, and disease activity was measured using DS28 ESR. Participants with comorbidities such as malignancies, infections, liver, renal, pancreatic disease, other autoimmune disorders, and recent blood transfusion and smoking history were excluded. The study population had a mean age of 46.9 years with a male-female ratio of 0.421. Hematological parameters, neutrophils, lymphocytes, platelets, CRP, and ESR were assessed in all the participants. Mean NLR and PLR were significantly higher in RA patients than control. NLR strongly correlated with ESR, R equal to 0.94, CRP 0.8, and DAS28R equal to 0.84. PLR correlated with DAS28R equal to 0.79, but not significantly with ESR or CRP. ROC curve analysis showed high predictive accuracy. NLR AUC equal to 0.92 and PLR AUC equal to 0.89 with respective cutoffs of 1.65 and 160.75. Based on DAS28, the majority had moderate disease activity, 56.65%, and 19.5% were in remission. About 34% had ESR more than 100, suggesting significant inflammation. 68% had elevated CRP, more than 6 mg per liter. Neutrophilia and lymphopenia in RA contributed to elevated NLR, reflecting systemic inflammation. NLR and PLR offer cost-effective objective markers with low inter-observer variability and readily available tools compared to DAS28, which includes subjective components. Limitations include a small sample size, short study duration, single-center data, and no follow-up, limiting generalizability. In conclusion, NLR and PLR significantly correlate with rheumatoid arthritis disease activity and can be used for early diagnosis, monitoring, and management. The next original article is on COVID. Effect of COVID-19 related lockdown on headache in adults, a report of a survey. Authored by Varsha Ambwani et al. The online survey explored how the COVID-19 lockdown impacted headache patterns among Indian adults. Conducted between May and June 2020 using SurveyMonkey, it involved 689 participants from designated red zones, complete lockdown area, with a history of primary headaches. Of the respondents, 17.2% reported an increase, 67.2% saw no change, and 15.5% experienced a decrease in the headache frequency. Predictors of increased headaches included anxiety, poor sleep, use of face masks, emotional stress, and more time spent in household. Interestingly, single status and decreased course predicted headache improvement. The study found a significant association between lifestyle disruptions such as screen time, limited mobility, and altered sleep, and headache frequency. It emphasized the psychosomatic effects of the lockdown and stressed the need for better public mental health strategies during such crises. The work contributes important data to the growing literature on the pandemic's neurological and psychological impacts and underscores the importance of maintaining routine care and psychological well-being during public health emergencies. The last original article in this edition is on the effect of iron overload on bone mineral density in patients with transfusion-dependent thalassemia, authored by Sonia Gupta et al. This cross-sectional study assessed the impact of iron overload on bone mineral density in patients with transfusion-dependent thalassemia at a tertiary care center in Punjab. The study included patients aged more than 5 years who underwent BMD scans during 2022. Findings revealed a high prevalence of low BMD, osteopenia in 61.2%, and osteoporosis in 17.7% of lumbar spine scans. Serum ferritin level, a surrogate marker for iron overload, were significantly elevated in those with lower BMD. At a cutoff of 1918 nanogram per milliliter, ferritin predicted osteoporosis with 80.4% sensitivity and 87.5% specificity. The study confirmed a strong negative correlation between ferritin and BMD, indicating that iron overload directly contributes to the skeletal demineralization. The authors recommended routine BMD assessments in TDT patients enable early intervention, prevent fracture risks. These findings call for enhanced surveillance strategies and tailored interventions to improve bone health in thalassemia patients, emphasizing timely chelation therapy and nutritional support. Now we come to the review articles. And the first review article is titled Interaction of Indian Culture and Ayurveda with Modern Medicine. This is authored by Hemraj R. Chandalia et al. This thoughtful and nuanced article explored the complex interplay between Indian cultural practices, especially Ayurveda, and modern medicine, drawing from historical, sociological, and medical perspectives. The authors evaluate how Ayurveda, rooted in India's Vedic heritage, continues to influence patient attitudes, beliefs, and treatment adherence. Ayurveda, based on Tridosha theory, Vata, Pitta, Kapha, remains deeply embedded in Indian consciousness, often overlapping with home remedies. Despite growing global interest, modern validation of Ayurvedic remedies remains scarce. Out of 32,519 scientific records, only 199 randomized trials on 98 Ayurvedic compounds were eligible for review. This calls for rigorous research and regulatory modernization. The article highlights how ancient systems, including Ayurveda, have yet to integrate scientific adaptability. Unlike modern medicine, attempts at evidence-based validation are necessary, particularly for widely used formulations in diabetes and metabolic disorders. For example, over 200 plant-based compounds have mild glucose-lowering properties, yet none have shown efficacy for advanced diabetes. The author also identifies significant cultural challenges, a trust deficit in physicians, poor continuity of care, and resistance to invasive interventions like injections. Moreover, the perception that modern medicine causes harm while Ayurvedic drugs are inherently safe leads to misuse and non-adherence. Myths and misinformations, both in India and abroad, further complicate the physician-patient dynamic. Ultimately, the article advocates a conciliatory, open-minded integration of both systems. Modern medicine should validate useful Ayurvedic treatments and incorporate them into preventive healthcare, especially for pre-diabetic states. Conversely, patients should be educated with empathy and scientific reasoning to ensure better health outcomes. Bridging these systems thoughtfully could enrich Indian healthcare while preserving cultural identity. The next review article is on expert opinion in management advancements in sarcopenia from muscle wasting to recovery, authored by Sanjay Kalra et al. Sarcopenia is a generalized and progressive skeletal muscle disorder characterized by reduction in the muscle mass, strength, and function, which affects all aspects of quality of life, including impairment in physical performance, psychological distress, and creates a vicious cycle of further deterioration. The prevalence of sarcopenia in elderly is 10 to 16%, and despite its substantial health implication, sarcopenia is underdiagnosed and undertreated and has not been given enough attention as it deserves. Sarcopenia can be determined by the occurrence of any two among these three: reduced muscle function, strength, and mass, measured using metrics such as grip strength, walking speed, or chair stand tests, lean mass percentage, and appendicular skeletal muscle index, ASMI, which helps to classify sarcopenia into three groups: pre-sarcopenia, sarcopenia, and pseudo-sarcopenia, also called as cachexia. Depending upon the severity, sarcopenia is a multifactorial syndrome that may be primary, in which there's age-related muscle loss due to poor intake, low BMR, etc., or can be secondary, which is associated with comorbid conditions leading to profound and chronic inflammatory response, accelerated muscle breakdown. Some special conditions are cachexia, a kind of secondary sarcopenia, is normally caused by severe muscle wasting conditions such as malignancies, heart failure, cardiomyopathy, and ESRD. Another classical example is sarcopenic obesity, the so-called hidden hunger. The pathophysiology of sarcopenia is complex, and interplay of multiple pathophysiological mechanisms like physical inactivity, decreased protein intake, chronic inflammation, insulin resistance, decreased blood flow, metabolic dysfunction, reduced number of motor neuron units, decreased hormonal and neuronal input, genetic and epigenetic factors such as fat, scar infiltration, nuclear or mitochondrial abnormalities, iatrogenic sarcopenia, drug-induced like anti-obesity medicines. Hence, because of this huge burden of sarcopenia, it must be screened for high-risk individuals, especially older adults, person living with obesity, diabetes, chronic medical or surgical conditions, CKD, CLD, malignancy, etc., and immobilized patients. A multimodal approach that combines early screening, early capture of red flags, prompt diagnosis, non-pharmacological measures like resistance exercise, nutritional support, and appropriate pharmacological therapy is recommended as the cornerstone in the management of sarcopenia. Sarcopenia screening typically begins at 50 to 60 years of age, but early screening should be started at 30 to 40 years in high-risk individuals. In nutritional support, one of the most important thing is adequate protein intake. Dietary protein intake in older adults with sarcopenia should be 1.2 to 1.5 gram per kg body weight per day, or 1 gram per kg per day for CKD patients, including high quality proteins from animal to plant sources, along with essential amino acid supplementations such as protein with high leucine content, BCAAs, HMB, creatine, beta-alanine, calcium, vitamin D as a part of balanced diet. Pharmacological treatment for sarcopenia are limited and only few drugs have been approved. One of them is nandrolone becanoate as a first-line treatment for individuals with severe symptoms and site of sarcopenia, recommended over testosterone due to its superior anabolic to androgenic ratio. It stimulates myogenic progenitor cells differentiation, IGF-1, signaling, and more molecular pathways for muscle and bone growth also increases S-APO levels. Hence, nandrolone decanoate may be considered as an adjunct for person with sarcopenia and associated osteopenia, osteoporosis, including refractory anemia. The therapy should be initiated solely in patients with sarcopenia confirmed by clinical diagnosis and or validated diagnostic criteria to prevent its misuse and harmful complications. Side effects of nandrolone such as mild acne or hirsutism are typically manageable and well tolerated in patients. Nandrolone should not be used in patients with hormone-sensitive malignancies such as prostate or breast cancer, hepatic dysfunction, thromboembolic events, HCD threshold 50%, pregnancy, lactation, and obstructive sleep apnea. Hence, patient-centric individualized therapeutic strategy should be made for prompt and effective management. The last review article is titled Revising Diabetes Classification, Insights, Challenges, and Clinical Relevance of the ANDIS Framework in the Indian Context, authored by Akriti Singh et al. The traditional classification of diabetes into type 1 and type 2 fails to reflect the wide variation in disease presentation, risk, and treatment response. The ANDIS framework, introduced in Sweden, proposes a data-driven model that divides adult-onset diabetes into 5 subtypes: severe autoimmune diabetes, severe insulin-deficient diabetes, severe insulin-resistant diabetes, mild obesity-related diabetes, and mild age-related diabetes. This model aims to improve risk prediction and personalize treatment based on underlying pathophysiology. In the Indian context, studies like Inspired and Welgen have shown that insulin deficiency is the predominant mechanism, especially in younger patients with SIDD being the most common subtype. Additionally, Indian-specific clusters such as insulin resistance, obese diabetes, and combined insulin resistant and deficient diabetes were identified. The therapeutic implications. SIDD, early insulin therapy, best treated with insulin sensitizers, for example, metformin. MOD, MARD, managed with lifestyle or minimal pharmacotherapy. Therefore, while the ND's classification provides valuable insight into complication risk, such as microvascular issues in SID and cardiovascular risks in SIRD, it has limited impact on changing current treatment strategies. Major challenges include the need for complex and expensive diagnostic tests like GAD antibodies and HOMA indices, which are often inaccessible in low resource settings. To improve real world relevance, the use of simpler, widely available markers like HbA1c, BMI, waist circumference is the most recommended. The broader adoption model must be simplified, validated across diverse populations, and shown to improve clinical outcomes. The NDIS model enhances our understanding of diabetes heterogeneity and stratifies patients by risk and treatment needs. But in its current form, it is limited by cost, complexity, and real world practicality, especially in countries like India. Future efforts must focus on simplification, validation in diverse population, and demonstrated clinical benefits to make it a tool for everyday use. Thank you for listening to the JAPI podcast. Have a good day.